If you ever make the fatal mistake of foraging and eating an Amanita phalloides mushroom, the infamous death cap, the actual tissue of that mushroom isn't what kills you.
Right, the mushroom itself is basically harmless on a tissue level.
Exactly. The molecules inside the death cap are not inherently fatal to human biology on their own. What kills you is actually your own body's defense system. Specifically, your liver intercepts those molecules, attempts to disarm them using its, standard biochemical protocols, and in the process accidentally converts them into an entirely new, unstoppable poison that it obliterates your cells from the inside out.
It's the ultimate biological irony, really. The very mechanisms that are designed to protect you from a toxic world are, well, they're weaponized against you. And that paradox sits at the very center of what makes this organ so fascinating.
Welcome to the Deep Dive. We are talking directly to you, the listener who wants the real story, the thorough, fascinating mechanics of how things actually work, without drowning in info overload. We're skipping the basic anatomy textbook definitions today. We assume you know where your organs are?
Yeah, we don't need to review basic biology.
Right. Instead, we are looking at the human liver as the body's ultimate biological multitasker. I mean, it's a relentless biochemical factory, a secret endocrine mastermind running global metabolism, and an organ capable of, Wolverine-level rapid regeneration.
And the sheer breadth of the liver's portfolio requires a massive array of literature to understand. So today we are pulling from microscopic anatomy journals, clinical guidelines on deciphering liver function tests, deep dives into the pharmacology of acute liver failure, and some newly published research on hormonal pathways that are literally rewriting endocrinology as we speak.
Okay, let's unpack this. Our mission today is to deconstruct this organ from its macrogeography down to the molecular factory floor, figure out what happens when it gets injured, and reveal how it secretly controls far more of the body than we give it credit for. Starting with the geography, we have to look at the vascular anomaly of the liver, because physically, it is built completely backward compared to the rest of the body.
It truly is a structural outlier. I mean, the liver weighs about 1,500 grams, making it the largest solid internal organ. But unlike your brain or your kidneys or your heart, which rely almost entirely on high-pressure, highly oxygenated arterial blood pumping straight from the lungs, the liver gets a mere 25% of its blood supply from the hepatic artery.
Which means 75% of the blood entering this organ, an organ performing over 500 intensely demanding metabolic functions, is coming from the portal vein.
Yes.
And that is venous blood. It has already circulated through the stomach, the intestines, the spleen, the pancreas. It's essentially deoxygenated.
It is entirely depleted of oxygen, yeah.
So I have to pause here because, frankly, the mechanics don't add up. Why would evolution intentionally position a major energy-hungry organ downstream from the gut? I mean, how does it survive, let alone run 500 chemical processes on what is essentially used oxygen-starved blood?
Because the liver isn't prioritizing oxygen. That's the trick. It is prioritizing access and interception. So, the portal vein is carrying blood that is poor in oxygen, sure, but it is incredibly rich in recently absorbed nutrients, amino acids, lipids, and crucially foreign chemicals and toxins from the gastrointestinal tract.
Ah, I see.
Yeah, by placing itself directly downstream of the gut, the liver gets first dibs on all the raw building blocks it needs to synthesize proteins and store glycogen.
It's setting up an unbypassable toll booth right outside the digestive system.
Precisely. It acts as the ultimate border checkpoint. And when we look at the internal macrostructure, surgeons utilize something called the Kuno system to map this out. Superficial anatomy divides the liver into a large right lobe and a smaller left lobe, but that's, well, it's practically useless for understanding how it functions surgically or medically.
Right.
The Kuno system divides the liver into 8 completely independent functional segments.
Independent meaning they don't share plumbing, at all.
Yeah, exactly. They don't share inflow or outflow. Each of those 8 segments has its own dedicated branch of the hepatic artery, its own branch of the portal vein, bringing in that gut blood, and its own bile duct for drainage.
Wow. And this is why living donor liver transplants are possible, right? A surgeon can resect segment 6 and segment 7 entirely, and because those segments operate as autonomous units, the rest of the liver doesn't even notice the disruption to the blood supply.
That segmental autonomy is just brilliant engineering. But to see how the oxygen-rich arterial blood and the nutrient-rich venous blood actually interact, we have to zoom way down to the microscopic level. The architecture here is generally mapped out in 3 different conceptual models, mostly depending on what physiological process you're trying to track.
The structural one is the classical hepatic lobule. I always picture this as a microscopic hexagon.
A hexagon is the perfect way to visualize it. At the very center of this hexagonal cylinder is a single central vein, and at each of the 6 outer corners of the hexagon, you have what's called a portal triad.
And a triad is basically the microscopic end of the line for those big vessels we just talked about. It's a tiny branch of the hepatic artery, a tiny branch of the portal vein, and a tiny bile duct, all bundled together.
Yes. So blood flows from those 6 outer corners, squeezing through these highly porous capillary channels called sinusoids, washing over the liver cells, the hepatocytes, and finally draining into that central vein in the middle.
Okay, that makes sense for blood flow.
Right, but meanwhile, the hepatocytes are busy manufacturing bile, which flows in the exact opposite direction, from the center of the hexagon outward toward the bile ducts at the corners. So if you are a pathologist tracking how bile drains, you might use the second model, the triangular portal lobule, which centers on the bile duct rather than the vein.
But the third model, the liver acinus, this is the one that really dictates how the liver survives, how it metabolizes drugs, and honestly, how it dies. Because the acinus model isn't about physical shapes, it's about the oxygen gradient.
Exactly. The liver sinus is diamond-shaped, and it divides the microscopic tissue into 3 distinct zones based purely on how close the hepatocytes are to the incoming fresh blood from that portal triad.
So it's about proximity.
Very much so. Zone 1 is the periportal zone. These cells are right on the front lines, immediately adjacent to the incoming hepatic artery and portal vein. Zone 2 is the transitional midzone, and Zone 3 is the perivenular zone, located at the very end of the line, right next to the central vein where the blood exits.
Let's put this into a concrete analogy because the zoning laws of the liver explain so much of its pathology. Picture a city's municipal water supply system. Zone 1 is the wealthy, exclusive neighborhood situated right at the reservoir. They get the absolute pristine, highly oxygenated water first.
Exactly.
And because they have abundant resources and oxygen, the cells in Zone 1 are tasked with the high-energy, oxidative jobs like liver regeneration, cholesterol synthesis, and gluconeogenesis, which is, the energy-intensive process of creating new glucose from scratch.
That's incredibly accurate. Zone 1 is specialized for oxidative metabolism. They have the oxygen to burn, so they do the heavy lifting for energy production.
But then you follow the pipeline down to Zone 3. They are at the absolute end of the line. By the time the blood washes through Zone 1 and Zone 2, almost all of the oxygen has been stripped out. So Zone 3 gets whatever hypoxic trickle is left over.
Yeah, it scraps.
Right. But worse than that, the liver assigns Zone 3 the dirtiest, most biochemically dangerous waste management jobs in the entire organ detoxifying drugs, breaking down metabolic waste and performing glycolysis.
And this geographical reality creates a massive double jeopardy for Zone 3. Because it operates on a razor-thin margin of oxygen, it is exquisitely vulnerable to ischemia. If you suffer massive blood loss, say from trauma, or go into septic shock, and your blood pressure plummets, the cells in Zone 3 simply suffocate.
Wow.
Yeah, they are the first to undergo ischemic necrosis because the oxygen never reaches them.
So they die of starvation. But on the flip side, because they are the designated waste management sector, they are loaded with detoxifying enzymes. So if you swallow a massive dose of a toxic chemical, the enzymes in Zone 3 go into absolute overdrive trying to dismantle it, and they end up taking the brunt of the toxic damage.
They die of toxic overload. It's a brutal neighborhood to exist in, but those Zone 3 enzymes are what keep the rest of the body alive.
Which brings us right into the factory floor of the liver, its role in xenobiotic metabolism and detoxification.
Xenobiotics being foreign chemicals, we're usually talking about pharmacological drugs, but it includes environmental toxins, plant alkaloids, basically anything non-native to human biology.
Yes, and the central physiological problem the body faces with xenobiotics is solubility. For a drug to be effective, it usually needs to be highly leakocylic, meaning fat-soluble.
Because if it isn't fat-soluble, it can't cross the lipid bilayer membranes of the cells in your stomach and intestines. It would just pass straight through your digestive tract unabsorbed. Exactly. The drug must be lipophilic to enter the bloodstream. But this creates a massive biological trap. Your kidneys are responsible for filtering your blood and excreting waste in your urine. But the kidneys can only excrete water-soluble compounds.
Okay, I see where this is going.
Yeah, if a lipophilic drug is filtered into the kidney tubules, it will simply dissolve right back through the tubule membranes and re-enter the bloodstream.
So without intervention, a single dose of a fat-soluble drug like ibuprofen or an antidepressant would just circulate in your blood forever, eventually building up to lethal toxic levels.
It would never leave. This is why the liver's first-pass metabolism is absolutely critical. You swallow a pill, it gets absorbed, enters the portal vein, and goes straight to the liver. The smooth endoplasmic reticulum inside the hepatocytes, particularly down in that vulnerable zone 3, has to act as a chemical conversion plant.
Right.
It has to take a fat-soluble molecule and physically alter its chemical structure to make it water-soluble so the kidneys can finally flush it out.
And this biochemical conversion happens in two distinct stages, phase 1 and phase 2 metabolism. And looking at the chemistry here, it's not just, breaking things down. Let's use an analogy. Imagine a drug molecule is a highly illegal, sophisticated smuggler's vehicle. It's stealthy, it easily slips across the border, the gut wall, because it's designed to blend into the lipid environment. Phase I metabolism is the liver intercepting that vehicle and forcefully modifying it.
It's essentially retrofitting the molecule. Phase I relies on an incredibly diverse family of heme-containing enzymes called the cytochrome P450 system. What these P450 enzymes do is use oxygen to introduce or unmask a polar chemical group on the drug molecule, usually a hydroxyl group, and oxygen bound to a hydrogen.
So the CYP450 enzymes act like customs agents, catching the smuggler's car and welding a massive, highly magnetic tracking beacon, the polar group, onto the chassis. It alters the fundamental structure of the vehicle.
That polar group makes the drug slightly more water-soluble, but more importantly, it gives the molecule a handle for the next phase. However, phase I is highly volatile. Well, by adding that reactive polar group, the CYP450 enzymes frequently create intermediate molecules that are far more biologically active or even more toxic than the original drug you swallowed.
This blew my mind in the sources. The liver isn't always neutralizing things. Sometimes it's actually synthesizing new active drugs.
Pharmacologists rely on this intentionally. We design drugs as inactive prodrugs. For instance, codeine has very little pain-relieving effect on its own. It's a prodrug. It relies entirely on a specific phase I enzyme, CYP2D6, to intercept it and chemically convert it into morphine inside your bloodstream.
That is wild.
Or take the anti-anxiety medication diazepam. Phase I strips parts of it away to create desmethyldiazepam and then oxazepam. Those are entirely distinct, highly active pharmacological compounds synthesized completely inside your own liver.
So phase I welds the reactive handle onto the molecule. But to get it completely out of the body, we need phase 2, which is conjugation.
Phase 2 takes that reactive intermediate from phase 1 and forces it to couple or conjugate with a massive, highly water-soluble endogenous molecule. We are talking about adding bulky groups like glucuronic acids, sulfate, or glutathione.
Going back to our smuggler analogy, phase 2 is the customs agents taking that car with the new magnetic handle and attaching a massive, heavy, unaerodynamic steel boot to the wheels. The vehicle is now incredibly bulky, totally inert, and highly water-soluble. When it hits the kidneys, the Border Patrol, they easily recognize it. It can't slip back through the membranes, and it's thrown out in the urine.
That is the perfect visualization of conjugation. Once conjugated, the drug loses its pharmacological activity and is rapidly excreted. But the system isn't foolproof. Lipophilic drugs can evade this entire liver factory through something called depot binding.
They hide.
They hide in your adipose tissue, your fat cells. THC, the active compound in cannabis, is incredibly fat-soluble. When it enters the bloodstream, a significant portion of it completely bypasses the portal vein and diffuses straight into your fat cells. It effectively hides from the liver's CYP450 system.
Then, over days or weeks, as fat is metabolized, the THC slowly leaks back out into the blood in tiny subclinical amounts.
Which is exactly why a water-soluble drug might clear your system in 12 hours. But THC metabolites can be detected in a urine screening 30 days after ingestion. The liver it can't metabolize what it can't catch.
Exactly. But when the liver does catch the chemical and the factory lines get overwhelmed, the results are catastrophic. We have to look at the specific biochemical vignette of acetaminophen paracetamol toxicity. It is the absolute textbook example of how phase 1 and phase 2 systems interact and how they fail.
Acetaminophen is arguably the most common over-the-counter painkiller on Earth. We take it without a second thought. But the pharmacology of an overdose is terrifying because it perfectly maps onto those vulnerable zone 3 cells we talked about earlier.
In a normal therapeutic dose of acetaminophen, say 1,000 milligrams, your liver's phase 2 conjugation system handles the vast majority of it immediately. It attaches sulfate or glucuronide to the molecule, renders it safe, and you excrete it. Phase I barely has to lift a finger. But if someone intentionally or accidentally takes a massive overdose, say an entire bottle what breaks.
The phase 2 pathway has a hard speed limit. The liver physically runs out of the sulfate and glucuronic acid needed to conjugate the drug. The pathway becomes completely saturated, so the liver has a huge backlog of unmetabolized acetaminophen, and it panic shunts all of it over to the alternative pathway. The phase I cytochrome P450 enzymes, specifically an enzyme called CYP2E1.
In phase I, as we established, modifies the molecule. It doesn't make it safe, it makes it reactive.
And in this highly specific case, CYP2E1 oxidizes the acetaminophen molecule and turns it into a highly electrophilic, incredibly toxic intermediate metabolite called NAPQI.
N-acetylbenzoquinone imine. NAPQI.
Yes. NAPQI is a cellular wrecking ball. It is an electrophile, meaning it aggressively seeks out electrons to bind with. If left unchecked, it will violently bind to the proteins and lipid membranes of the liver cell itself, essentially shredding the cell's structural integrity.
That sounds disastrous.
It is. Now, normally the liver has a failsafe. It stores a powerful antioxidant peptide called glutathione. Glutathione acts as a sacrificial electron donor. It happily binds to the NAPQI and neutralizes it before it can damage the cell.
But in an overdose, there is so much acetaminophen being forced through phase I that the liver produces the tsunami of NAPQI. It burns through the entire reserve of glutathione.
The glutathione is entirely depleted, and once the glutathione is gone, the unneutralized NAPQI attacks the mitochondria and the cellular macromolecules. This triggers a rapid, irreversible cascade of hepatocyte necrosis. The cells literally burst.
Wow.
And because those COP2E1 enzymes are highly concentrated down in zone 3 around the central vein, the massive cell death begins in zone 3 and aggressively radiates outward.
You're touching on a paradox here because the sources point out that certain patients are at vastly higher risk of dying from an acetaminophen overdose simply because of their lifestyle. Chronic alcohol consumption, for instance.
It creates a lethal synergy. Chronic alcohol use actively induces the liver to produce more of that specific phase I enzyme, CYP2E1, because alcohol is metabolized by the same pathway.
Right.
So if you are a chronic drinker, your liver factory is supercharged with CYP2E1. If that patient takes an overdose of acetaminophen, their massive army of phase I enzymes converts the drug into toxic NAPQI at a vastly accelerated rate, blowing through their glutathione reserves almost instantly.
It's an accidental perfect storm. The treatment they give in the ER for this is N-acetylcysteine, or NAC. I assume this intervenes in that biochemical cascade.
Yes, N-acetylcysteine is essentially a direct precursor amino acid. By giving the patient massive intravenous doses of NAC, you are rapidly providing the liver with the raw materials it needs to synthesize fresh glutathione. You are desperately trying to rearm the liver's natural defense system to neutralize the NAPQI before the necrosis becomes fatal.
So we've seen how the liver ruthlessly manages external chemicals, playing this incredibly high-stakes game of molecular modification. But the sources reveal a completely different side of the organ. The liver isn't just passively defending the body from the outside world. It is actively, secretly commanding the internal world. It is an endocrine mastermind.
We have a very compartmentalized view of the endocrine system. We think of the thyroid gland controlling metabolism, the pituitary gland in the brain acting as the control center, the adrenal glands managing stress. The liver is rarely mentioned in basic biology as an endocrine organ, yet it is arguably the central pillar of systemic endocrinology.
Let's start with what it physically manufactures, the classical endocrine functions. It directly synthesizes major systemic hormones.
Exactly. Take growth hormone, for example. The pituitary gland secretes growth hormone, but growth hormone itself does very little to physically make your bones or muscles grow. The pituitary hormone travels to the liver and signals the hepatocytes to synthesize and release IGF-1, insulin-like growth factor 1.
So it's a middleman.
More than that, it is the liver's IGF-1 that actually travels out and triggers cellular proliferation and tissue growth across the entire body.
Okay, so the liver is the actual contractor doing the building. The pituitary is just the architect sending the plans.
Precisely. The liver also constantly secretes angiotensinogen. This is a massive precursor protein that circulates constantly in your blood. Without it, the kidneys and lungs would have no substrate to create angiotensin II, meaning your entire blood pressure and fluid volume regulation system would simply cease to exist. Furthermore, it regulates your skeletal system through vitamin D.
Right, because the vitamin D we synthesize in our skin from sunlight or absorb from fortified milk isn't actually biologically active yet.
It's a prohormone. It's completely useless to your bones in that state. The liver uses its cytochrome P450 enzymes to hydroxylate the molecule, adding an oxygen and hydrogen to the 25th carbon position. This creates 25-hydroxyvitamin D, which is the main circulating storage form of the vitamin.
Ah, I see.
The kidneys eventually do the final activation, but if the liver fails to do that initial 25-hydroxylation step, your body cannot absorb calcium from your diet, leading to rapid loss of bone density.
So it's synthesizing these massive precursors, but it's also acting as the grand central station for processing everyone else's hormones.
Yeah.
It controls the off switches and the on switches.
It's the ultimate metabolic arbiter. Let's look at the thyroid. The thyroid gland actually secretes mostly T4, a relatively inactive storage hormone. Your cells run on T3, the active form. A massive 80% of the biologically active T3 in your body is generated peripherally, and the liver is a primary site where specialized deiodinase enzymes physically clip an iodine atom off the T4 molecule, converting it into active T3. The liver dictates your metabolic rate by controlling how much thyroid hormone is activated.
And it controls the off switches for the gut, too, like GLP-1.
GLP-1 is a crucial incretin hormone. When you eat, your gut secretes GLP-1 to tell your pancreas to produce insulin, but you don't want insulin pumping forever, or your blood sugar would crash and you'd slip into a coma.
Right, that would be bad.
Very. The liver expresses an enzyme called DPPIV, which rapidly inactivates GLP-1 almost as soon as it passes through the portal circulation. It exerts exquisite timing control.
And beyond activation and deactivation, it physically controls the transport logistics. We talked about how lipophilic drugs can't travel in blood easily. Steroid hormones, testosterone, estrogen, cortisol, and thyroid hormones are highly lipophilic. They're essentially pure cholesterol derivatives.
They cannot dissolve in the watery plasma of the blood. If left alone, they would just clump together into useless lipid droplets. So the liver synthesizes specialized transport proteins, molecular taxicabs.
The binding globulins.
Yes. The liver continuously pumps out sex hormone binding globulin, SHBG, for testosterone and estrogen, cortisol binding globulin, CBG, for your stress hormones, and thyroxine binding globulin, TBG. And here's the critical mechanism. A hormone bound to a carrier protein is biologically inactive. It can't enter a cell. Only the tiny fraction of free hormone floating in the plasma can actually trigger a biological response.
So by simply ramping up or scaling back its production of SHBG, the liver can instantly dial down or dial up the amount of active testosterone and estrogen affecting your tissues without the testes or ovaries changing their production rates at all.
The liver controls the bioavailability of the entire endocrine system.
Here's where it gets really interesting, because all of that is the classical, established understanding. But we are looking at research papers that dive into newly discovered hormonal roles of the liver that are completely paradigm shifting, the alpha cell liver axis.
This is where modern endocrinology is being rewritten. We have long understood the basic push and pull of blood sugar. In the pancreas, beta cells produce insulin, which lowers blood sugar by forcing cells to absorb it. Alpha cells in the pancreas produce glucagon, which raises blood sugar by telling the liver to dump its stored glycogen into the blood.
A simple seesaw. Insulin lowers, glucagon raises.
Exactly. But researchers set up a fascinating experiment. They genetically engineered mice to lack glucagon receptors on their liver cells. The pancreas was producing glucagon perfectly normally, but the hepatocytes in the liver were completely deaf to the signal. They couldn't bind the hormone.
So you'd expect the mice to just have low blood sugar because the liver isn't releasing glucose.
You would. But when the researchers examined these mice, they found something astonishing. The mice had developed massively diffusely enlarged pancreases. When they looked at the tissue under a microscope, the pancreas was stuffed with a staggering overproliferation of alpha cells. The alpha cell population had exploded.
Wait, if the liver's receptors are broken, why would the pancreas aggressively grow more alpha cells?
Because the communication isn't a one-way street, the liver senses that it isn't receiving the glucagon signal. It detects the interruption in the metabolic circuit. In response, the liver continuously synthesizes and secretes a newly recognized liver-derived humoral signal back into the bloodstream. It sends a hormonal message directly to the pancreas, essentially screaming, "I am not receiving the signal. Produce more alpha cells. Send more glucagon."
The liver is physically altering the cellular architecture of a completely different organ to meet its own metabolic demands.
The liver exerts a direct negative feedback loop on pancreatic mass. And this brings us to an entirely new class of liver-secreted hormones called hepatokines. The liver isn't just a passive storage depot, it is secreting signaling proteins that modulate global metabolism.
Hepatokines like fetchun A and FGF21, what do these actually do at the cellular level?
They are essentially master dials for insulin sensitivity. Fetroin A is secreted by the liver and travels to skeletal muscle and adipose tissue. It binds to the insulin receptors on those tissues and physically blocks the insulin signaling cascade. It decreases insulin sensitivity.
Oh, wow.
And FGF21, on the other hand, acts in the opposite direction. It promotes glucose uptake, increases insulin sensitivity, and incredibly, it even crosses the blood-brain barrier to act on the hypothalamus, reducing the behavioral desire for sugar intake.
So when you combine the alpha cell liver axis, the control of hormone transport proteins, and the secretion of these hepatokines, we usually think of the brain or the thyroid as the body's ultimate control centers. But based on this, is the liver actually running the entire metabolic show behind the scenes?
The clinical proof of this is devastatingly clear. When we look at a patient with end-stage cirrhosis, where the liver architecture is replaced by fibrotic scar tissue, the patient doesn't just get jaundiced. They suffer a total systemic endocrine collapse.
Because the Grand Central Station is shut down.
Exactly. Men with advanced liver failure develop profound hypogonadism, testicular atrophy, and gynecomastia, the development of breast tissue. Why? Because the failing liver can no longer degrade circulating estrogens, and it stops producing SHBG, completely warping the free estrogen to testosterone ratio.
That is just, it's wild how connected it is.
They develop severe osteoporosis and bone fractures because the liver is no longer hydroxylating vitamin D or producing IGF-1. They develop low T3 syndrome because the deiodinase enzymes are gone, plunging them into cellular hypothyroidism. The systemic failure proves the liver's centrality. The collapse of the liver dictates the collapse of the entire endocrine system.
That is genuinely staggering. So if you're listening to this and realizing how utterly dependent your entire biological existence is on this organ, the natural question is, how do we monitor it? When you go in for an annual physical and get a blood panel, the doctor always runs liver function tests. But our clinical sources make a massive point of emphasizing that this entire concept is a dangerous misnomer.
Calling them liver function tests, or LFTs, is a historic relic that we are still stuck with. The standard LFT panel, which includes ALT, AST, ALP, bilirubin, and GGT, is routinely ordered on almost every patient in the developed world. But the vast majority of these biochemical markers do not measure liver function in any capacity whatsoever.
If these tests just measure enzymes, what are they actually showing? They are markers of liver injury.
Precisely. They are a casualty report, not a productivity report. Let's look at what you are actually measuring when your doctor tells you your ALT is elevated.
ALT is alanine aminotransferase, and AST is aspartate aminotransferase. These are enzymes.
They are intracellular enzymes. Their job is to facilitate amino acid metabolism. As long as a hepatocyte is healthy and its lipid membrane is structurally sound, those enzymes stay sealed inside the cell where they belong. The blood concentration should be extremely low.
But if the cell takes damage...
If the cell membrane is damaged, whether it's attacked by the immune system reacting to hepatitis B, poisoned by a drug metabolite like NAPQI, or stretched and inflamed by lipid accumulation and fatty liver disease, the membrane becomes porous. It leaks. And the ALT and AST physically spill out of the cytoplasm of the dying liver cell and into the systemic bloodstream. When we draw your blood and detect high ALT and AST, we aren't measuring what your liver is actively synthesizing. We are detecting the microscopic debris of bursting, dying hepatocytes.
Which is the hepatocellular pattern of injury. The cells themselves are exploding. But what about the other pattern? Because the sources differentiate between hepatocellular injury and cholestatic injury.
Cholestatic injury refers to the plumbing, the biliary system. If a patient has a gallstone lodged in their common bile duct, or a stricture or a tumor compressing the ducts, the bile cannot drain into the intestines. The fluid dynamics change. Back pressure builds up inside the tiny bile canaliculi inside the liver.
It's like tripping a garden hose.
Yes, and bile contains bile salts, which are essentially powerful biological detergents. When they accumulate under pressure, they irritate the epithelial cells lining the bile ducts. This physical and chemical stress directly induces those duct cells to rapidly synthesize and release massive amounts of two specific enzymes, alkaline phosphatase, or ALP, and gamma-glutamyl transferase, GGT.
So an elevated L test tells you the factory workers are dying. An elevated ALP-GGT tells you the factory's waste plumbing is blocked and backing up.
Exactly. And the nuance between those enzymes is critical. Look at ALT versus AST. ALT is found primarily in the cytoplasm, the watery fluid inside the cell. AST, however, is heavily concentrated deeper inside the cell, locked within the mitochondria.
So if you're looking at your own lab panel and you see that your AST is significantly higher than your ALT, which is an inversion of the normal pattern, what does that mean?
It means the damage isn't just a superficial membrane leak. The damage is profound enough to physically destroy the mitochondria deep inside the cells. We see this classic AST to ALT ratio greater than 2 in alcoholic hepatitis because alcohol toxicity aggressively targets mitochondrial function.
Oh, that makes sense.
Conversely, if the ratio is greater than 1 yo in a non-drinker, it's often a major red flag that the subtle inflammation has progressed to advanced fibrosis or cirrhosis.
But wait, if these tests only measure leaking enzymes and backed up plumbing, how do you actually measure the liver's true function, its ability to do those 500 jobs?
To measure true function, you must measure synthesis and clearance. For synthesis, we look at serum albumin. Albumin is a massive protein manufactured exclusively by the liver that acts like a sponge, keeping fluid inside your blood vessels so it doesn't leak into your tissues. Because albumin has a long half-life of about 20 days, it is an excellent marker of chronic liver function. If albumin is low, the factory has been failing for weeks.
And for acute synthesis?
We look at the INR, or prothrombin time. This measures the speed at which your blood clots. The liver synthesizes almost all of your coagulation factors, and these factors have a very short half-life. Some only last a few hours. If your liver function drops today, your INR will shoot up tomorrow because the liver failed to replace the clotting factors.
And for clearance, we look at bilirubin.
Yes. Bilirubin is the toxic yellow breakdown product of old red blood cells. The liver must actively extract it from the blood, conjugate it, and excrete it into the bile. If the liver loses its metabolic function, bilirubin accumulates in the tissue and the patient turns physically yellow. Jaundice is the ultimate visual marker of functional failure.
Which sets up this incredible, terrifying paradox in clinical medicine. Our sources state that 1 to 9% of completely asymptomatic people walking down the street right now have abnormally elevated LFTs.
That is a staggering public health metric, and the vast majority of those elevations are driven by MASLD, metabolic dysfunction-associated steatotic liver disease, previously known as fatty liver disease. The excess triglycerides stored inside the hepatocytes trigger a chronic, low-grade inflammatory state. The cells are slowly dying over decades, causing a constant low-level leak of ALT and AST into the blood.
So the patient feels fine, but their liver is slowly replacing dead functional tissue with useless scar tissue.
Exactly.
But here's the inverse of that paradox. You can walk into an intensive care unit and find a patient with end-stage cirrhosis. Their liver is a shrunken nodular rock of dense fibrosis. It is completely failing. And yet their ALT and AST lab results might come back perfectly normal. How is a dead liver producing normal labs?
Because they have completely burned out the organ, you need living hepatocytes to burst and release enzymes. If the liver tissue has been entirely replaced by fibrotic scar tissue, there are simply no healthy cells left to die. The battle is over. The casualty count drops to 0 because the army is already dead.
A normal ALT in an end-stage patient isn't a sign of health. It's a sign of absolute depletion.
Which is why relying solely on LFTs without understanding the clinical context and the synthetic markers like INR is incredibly dangerous.
So a condition like MASLD or chronic cirrhosis represents the slow, agonizing degradation of the factory over decades. But our critical care sources detail what happens when this entire 1,500-gram factory just abruptly, violently shuts down all at once. Acute liver failure.
Acute liver failure, or ALF. It is rare, but it is one of the most dynamic, catastrophic, and rapidly lethal emergencies in modern medicine.
The sources define it very specifically. This isn't acute on chronic failure. This is a patient who had a perfectly healthy liver on a Tuesday, and by Friday they are fighting for their life.
ALF is defined by a rapid timeline of severe deterioration. The defining clinical hallmark is the onset of hepatic encephalopathy, profound neurological and brain dysfunction. Shortly after the patient first turns yellow with jaundice, we classify it strictly by time. Hyperacute liver failure means encephalopathy develops within just 1 week of the onset of jaundice. Acute is between 1 and 4 weeks. Subacute is between 5 and 12 weeks.
And what triggers a healthy organ to just nosedive into hyperacute failure?
In the Western world, the overwhelming leading cause is paracetamol overdose, driven by that NAPQI necrosis we discussed earlier. But we also see idiosyncratic drug-induced liver injury, or DLI.
Idiosyncratic meaning it's not predictable based on the dose.
Exactly. A patient takes a completely standard course of a common antibiotic, like amoxicillin clavulanate or an herbal supplement, and for unknown genetic reasons, their immune system mounts a massive hypersensitive attack on their own liver, completely destroying it in days. Globally, acute viral hepatitis, particularly hepatitis A, B, or E, remains a massive driver of ALF. And of course, rare toxins like the M-metaphthalloids mushroom.
Regardless of the cause, when the liver goes offline, the clinical syndrome that follows is like watching a biological domino effect. Every other major organ system derails.
Because the central hub of homeostasis is gone. Let's look at the hematological cascade. You see a profound, unique coagulopathy. The liver has stopped synthesizing clotting factors, so the patient's blood becomes incredibly thin. They're at massive risk of spontaneous, fatal hemorrhage.
But the paradox is that they are also at risk of clotting.
Yes, it's a completely deranged coagulation state. The liver also produces the anticoagulant proteins like protein C and protein S, which prevent your blood from clotting uncontrollably. When the liver fails, both the gas pedal and the brakes of the coagulation system are destroyed simultaneously.
That is terrifying.
It is. The patient can bleed to death from a tiny IV line puncture while simultaneously throwing microscopic blood clots into their kidneys and lungs.
And metabolically, they crash.
Profound hypoglycemia. Because zone 1 has died, the liver can no longer break down stored glycogen or perform gluconeogenesis. The brain is entirely reliant on a steady stream of glucose, so the patient will slip into a hypoglycemic coma if not aggressively infused with the dextrose.
And then there's hepatorenal syndrome. The kidneys fail, but not because the kidneys are diseased.
The kidneys themselves are completely healthy, but the failing liver releases a massive storm of vasodilating chemicals into the splanchnic circulation, the blood vessels around the gut. These vessels dilate massively, pooling blood in the abdomen. The systemic blood pressure drops precipitously.
So the kidneys react to the low pressure.
Exactly. The kidneys detect this drop in pressure, assume the body is bleeding to death, and reflexively clamp down their own blood supply to conserve volume. They essentially starve themselves of oxygen in a misguided attempt to save the body.
But the most terrifying complication, the ultimate marker of ALF, is hepatic encephalopathy. When the liver's detoxification plant shuts down, the brain pays the ultimate price.
It is a devastating neurological decline. We discussed how the liver normally detoxifies ammonia, which is a toxic byproduct of bacterial protein digestion in the gut. Normally, the liver converts ammonia into harmless urea, which is excreted by the kidneys. In ALF, that conversion stops. Ammonia levels skyrocket in the blood.
And ammonia easily crosses the blood-brain barrier.
It floods into the central nervous system. Inside the brain, specialized support cells called astrocytes try to protect the neurons by absorbing the toxic ammonia and converting it into glutamine. But this creates a fatal osmotic gradient. Glutamine acts like a microscopic sponge. It rapidly draws water from the bloodstream into the astrocytes via osmosis.
The brain cells are physically filling with water.
The brain is actively swelling. This is cerebral edema. The brain is encased in a rigid, unforgiving bone vault, the skull. As the tissue swells, the intracranial pressure rises exponentially. If left unchecked, the swelling brainstem is forcefully pushed down through the opening at the base of the skull, the foramen magnum. This is called brain herniation, and it results in immediate brain death.
And our clinical sources map this neurological descent using the West Haven criteria. It doesn't start with a coma. It starts subtly.
Grade 1 encephalopathy is insidious. The patient might just exhibit an inverted sleep cycle, mild confusion, or a bizarre, inappropriate euphoria. You ask them a question, and they just have trouble finding the words. By grade 2, the lethargy is obvious. They are disoriented to time, and you see the classic physical sign. Asterixis.
The flapping tremor.
Yes. If you ask the patient to hold their arms straight out in front of them and bend their wrists back, their hands will violently, rhythmically flap forward and back. It isn't a true tremor, it's a negative myoclonus. The toxic encephalopathy is causing split-second losses of postural muscle tone. The brain briefly forgets to hold the hand up, it drops, and then reflexively snaps back up.
And from grade 2, it accelerates rapidly into critical territory.
Grade 3 is marked by severe confusion, paranoia, and extreme somnolence. The patient is largely unconscious and only rousable to intense physical stimuli. By grade 4, the patient is in a deep, unarousable coma. They lose their brainstem reflexes, meaning they can no longer protect their own airway and must be immediately intubated.
So put yourself in the shoes of the intensive care team. You have a patient sliding from grade 2 to grade 3. Their brain is actively swelling, their blood isn't clotting, their kidneys are shutting down. The liver's regenerative capacity is incredible, but it takes time. So when the liver stops detoxifying, the brain pays the price. How do doctors decide who gets a transplant when time is running out?
It is arguably one of the most harrowing, high-stakes ethical and medical decisions in modern critical care. You are dealing with an incredibly scarce resource deceased donor livers. The wait list is brutally long.
So you had to be absolutely certain.
You cannot transplant a patient who might organically regenerate and recover on their own because you are subjecting them to a massive, highly morbid surgery and sentencing them to a lifetime of powerful immunosuppressive drugs. But if you wait just 12 hours too long to see if they recover, they will suffer irreversible cerebral herniation and die. You have to thread an incredibly tight needle.
So how do they mathematically draw that line?
In the UK, and widely adopted across the globe, transplant centers utilize the King's College criteria to determine exactly when an ALF patient must be placed on the super urgent transplant list. The criteria are mathematically strict, completely devoid of subjective emotion, based purely on biochemical markers of systemic failure.
For paracetamol-induced liver failure, our sources outline 2 distinct pathways to qualify for the list. What is the first trigger?
The first pathway relies on a single dire physiological marker. If, despite maximum medical resuscitation and fluids, the patient's arterial blood pH drops below 7.3.
Meaning their blood is becoming dangerously acidic?
Yes, a severe lactic acidosis. It means the liver's capacity to clear lactate has completely failed and cellular metabolism across the body is collapsing. An arterial pH under 7.30 in the context of a paracetamol overdose statistically indicates that mortality without a transplant is near certain.
And what if their pH is holding above 7.30? What is the second pathway?
The second pathway requires a triad of massive simultaneous organ failures. The patient must hit all 3 of the following thresholds. First, a severe coagulopathy, defined by an INR greater than 6.5. Second, massive renal failure, defined by a serum creatinine over 300 micromoles per liter. And third, they must be in grade 3 or grade 4 encephalopathy.
So you literally have to prove with blood tests that the patient's blood has completely lost the ability to clot, their kidneys are effectively dead, and their brain function is collapsing into a coma all at the exact same time before you authorize the organ.
Yes. The medical weight of this algorithm is immense. The critical care team must monitor the patient hour by hour, running constant blood gases, checking the INR, monitoring the ammonia and the West Haven grade. They are watching the patient deteriorate, waiting for the exact biochemical window where natural survival drops to 0, making a transplant their only hope.
So what does this all mean? If we step back from the King's College criteria and look at the entire journey we've just taken, the liver is a 1,500-gram paradox. It sits quietly tucked under our ribs, this highly structured, geometric biochemical plant. It intentionally subjects its own cells to hypoxia just to intercept the toxic payload from our gut. It meticulously retrofits drug molecules, commands the pancreas to grow new cells, and acts as the master dial for the entire endocrine system. Yet the moment it fails, it violently drags every other major organ down with it.
It is the ultimate unsung hero of human homeostasis. It silently bears the brunt of our dietary choices, our environmental exposures, and our pharmacological interventions. It absorbs the damage so the brain and the heart can survive.
I want to remind you, the listener, of the sheer scale of what is happening inside you right now. Every single time you take a painkiller for a headache, every time you eat a meal or process a hormone, your periportal zones and cytochrome P450 enzymes are working overtime for you. They are performing billions of molecular modifications a second to keep your complex biology in perfect balance.
Our physiological existence relies entirely on its continuous, quiet labor.
I want to leave you with one final mind-bending fact from our sources that we barely touched on.
Okay.
We've talked about how resilient the liver is, but consider its cellular origins. Before a fetus is even 32 weeks old in the womb, its bones are essentially just cartilage. They aren't developed enough to contain functional bone marrow.
So they cannot produce blood cells.
Exactly. So the liver steps up. It completely changes its biological profile to run a process called extramedullary hematopoiesis. The embryonic liver physically acts as the body's bone marrow, manufacturing the red blood cells the fetus needs to survive until the skeletal system can take over. And even more astonishingly, a fully developed adult liver retains an almost magical prehistoric ability. It can regenerate its entire self, full structural mass, full vascular plumbing, full metabolic function for as little as 25% of its original tissue.
And it does this not just through stem cells, but through the rapid hyperplasia and division of mature, fully differentiated hepatocytes. It simply regrows.
It is the only solid organ in the human body that can do this, which raises the ultimate question. If medical science could eventually map and unlock the deep molecular secrets of how the liver achieves this miraculous Wolverine-like regeneration, could we one day coax our other organs to heal themselves in the same way? Could we teach a heart to physically regrow its muscle after a massive myocardial infarction? Could we teach the brain to regenerate its neural networks after a devastating stroke? The blueprint for human regeneration already exists inside you, sitting quietly just under your right ribs. Let that marinate.